Hi, everybody. Today we are going to be reviewing genetics, diagnostics for pregnancy, A&P development, high-risk pregnancy, some of those things. So this is chapter 6 through 10 in the book, and week 2. So when we start with genetics, you should have already learned about a lot of this stuff, but basically what we're thinking about is the number of chromosomes we have, and if we have an abnormality in our chromosomes, then that can affect the way we grow our babies. So if we have an abnormality in numbers, we can have a monosomy or trisomy. Our most common trisomy is going to be Down syndrome. Okay. We can also have some abnormalities in chromosomes that can cause fetal loss, and we can have early pregnancy loss and things like that. And sometimes we don't even know that that was the cause, because if it's early enough, they don't always test them. So some examples that we're thinking of for our trisomies. The one that we just mentioned, Down syndrome, is our more common one. This one, these kiddos can live a full life, but they have some deficits. So oftentimes they have heart conditions. They can have some cognitive development issues. They have some visual things you can see. So they'll have like the enlarged tongue, brush-filled spots on their eyes, absence of the semi increase in their hands. There's things with their toes, the gap between the toes. I'm trying to think, low set ears. There's a lot of different things that go with it. And so oftentimes these kids have higher incidence of infections and things like that too. Our other trisomies are not usually conducive with life. So trisomy 18 is Edwards syndrome, and trisomy 13 is Pato syndrome. These babies don't usually survive, sadly. So the things that we think about that can contribute to some of our anomalies and things like that have to do with inheritance. Okay, so if we think about, for example, you can have a unifactorial inheritance where it is based on the dominant and the recessive genes. So if my husband carries something and I carry it, a good one for this is not actually like an anomaly, but something that some people can really think about, has to do with eye color. So let's use that. With eye color, blue eyes is a recessive gene. Okay, so if you have a parent with a dad with brown eyes and a mom with brown eyes, you would expect their babies to have brown eyes, right? But if they carry that recessive gene, if in their background somewhere someone had blue eyes, and same with mom, those two genes could come together and make a baby with blue eyes. And that's what this first picture is looking at. Okay, so if the dad carries it, the mom carries it, we'll have one that that has brown and doesn't carry the recessive gene. We'll have two that have brown but carry the recessive gene for blue, and then we can have a child that has blue eyes. So this is also true for things like cystic fibrosis, sickle cell, stuff like that. If we have genes that are recessive, maybe mom and dad don't know they carry it. Okay, I had a friend who she carried the gene for cystic fibrosis, and she didn't find out till after she was pregnant. And then she found out her husband also carried the gene for cystic fibrosis. And so they can do that by finding out with a carrier screening. So that's on the slide here. This is where they can do a blood test and look and see, well, what do you carry? Okay. For my friend, she didn't find out till after she was already pregnant. So then they had to do other things to determine if their baby had cystic fibrosis. All right. So that's how dominant and recessive genes work, and how we can use a carrier screening even before she gets pregnant, so we know if there's a risk of having certain conditions. For multifactorial inheritance, this is are most common. And unfortunately, this isn't something we can predict. This isn't something that we can screen for. Okay, so we have a genetic component, but we also have an environmental component. And so there's a lot of factors that play into it. And so for these kids, we oftentimes don't know. Okay, so this is like your cleft lip, your cleft palate, some heart conditions, sometimes neural tube defects. But for neural tube defects, we have something we can do to try to mitigate that, which we'll talk about in a second, right here. So if you guys think about what you know, most of you, when I ask in class, what do we have moms take to help prevent neural tube defects? Everybody says folic acid. Okay. In order for this to be effective, though, guys, we need to take folic acid before she gets pregnant. Okay. If you look at the statistics on the slide, the neural tube, it closes in the first trimester. I believe it's in the first 9 weeks. And so if she's taking folic acid before she gets pregnant and she takes it into the first trimester, we're going to have the best effect. Okay. And what we're hoping for then is that neural tube will close. All right. If it doesn't close completely, that's where we have a problem. And so it's usually spina bifida or anencephaly. And spina bifida is like, this is a myelomeningeal seal on this baby here from a spina bifida, where it actually outpouches and comes outside. And then anencephaly causes a significant portion of the brain to not develop at all. And those babies don't survive. All right, so then we have lots of non-genetic factors, a lot of other things that affect how we grow our babies. So if we think about for a second, statistically, 50% of pregnancies in the United States are not planned. Okay, and so we talked about in class the importance of preconception counseling and getting a handle on comorbidities and getting moms healthy before they get pregnant. Oftentimes they get pregnant, they might not even know. They might not even know they're pregnant for a while. And all of our organ systems are developing in those first 8 weeks. And so during that time, maybe we're not eating well. Maybe we're drinking alcohol, using drugs, smoking cigarettes, doing all of these things that can cause permanent damage to the development of the organs. Okay. And so we're thinking about a lot of these things that are completely preventable. All right. So if a nurse has discussed teratogens with a client during preconceptual counseling, the client demonstrates understanding after making which statement? So read the answers and see what you think. So the answer to this is number 4. Exposure to teratogens poses the greatest risk during the first 8 weeks. And that's just what we were talking about right here on this slide, that teratogens are completely preventable, right? And it has the greatest effect on the organs during the embryonic period. And the embryonic period is those first 8 weeks of development, okay? All right, amniotic fluid. So we're going to start talking about the different things that that happen with a pregnancy that are separate from what you've already learned about with your normal med-surg patient. Okay, so amniotic fluid and membranes. The amniotic fluid is initially made up from plasma and diffused from maternal blood. And as the baby grows, their body starts secreting its own fluids as well. And the baby then starts urinating, and all these things combine to make up the amniotic fluid. The amniotic fluid has a lot of really important jobs for growing our baby. Okay, it's going to cushion our baby from trauma if mom takes, a basketball to the belly or something like that. It helps maintain the baby's body temperature. It maintains fluid and electrolyte balance. It gives the baby room to move. Because think if the membranes were all just on the baby, then they wouldn't be able to move. And if they can't move, then their muscles and their skeletal system are not developing properly. The other thing that it does is the baby actually breathes it. Their body makes breathing movements. The diaphragm drops and pulls in and then pushes out. And the amniotic fluid goes into those alveoli and helps expand them. It keeps them from collapsing and aids in lung maturity. So amniotic fluid is very important for lung development. Okay. So all of this amniotic fluid is around the baby. Okay, and it stays inside. We have the placenta, and then we have these membranes that come all the way around, kind of like a water balloon. The baby's inside here, and then the amniotic fluid is in that. And so the membranes that are surrounding are the chorion and the amnion. And most often you don't see these separately, okay, because they're both very thin and they lie together. All right, but later when we talk about infections like chorioamnionitis, it's an infection of the chorion and the amnion. So these two tiny, thin membranes lie together and they encompass the baby and the fluid and all of that. So the chorion is the membrane that is from the embryonic and fetal portion of the placenta, and the amnion is the second membrane that goes around, and together these protect the baby from things like infection that comes in. It holds the amniotic fluid in place, things like that. And so the amniotic fluid in here at 37 weeks, which is term, there's like about 1,000 mLs of fluid that's encompassed in that. If you have too much fluid, we call that polyhydramnios. Poly is a lot and hydra is water. Okay. If you have polyhydramnios greater than 2,000 mLs, this can be a sign of like a fetal anomaly. It can also be a sign of diabetes. So since babies are supposed to drink the amniotic fluid and pee the amniotic fluid out, if you have high levels of fluid, that could be there's a problem either with the swallowing or the peeing for the baby, or it can be, again, diabetes. Okay, because that can cause an excess in fluid as well. If you have too little fluid, we call it oligohydramnios. This is less than 400 mLs. We often see this with things like if she's past her due date, the fluid level can go down. Some anomalies affecting the kidney and the bladder can cause this because they're not able to pee properly. Also, we can see this with preeclampsia, which we'll learn about in a different week. For fetal circulation, our baby, there's a lot of information in the book about fetal development, okay? The first thing before we talk about circulation, I want to point out is that we already said the embryonic period is through the 8th week. This is the most critical for our organs developing and all those things. The fetal period starts at week 9, and then the baby is a fetus for the rest of the pregnancy, okay? And then the way that the placenta forms and we start getting what's the words I'm looking for? We're getting circulation from mom into the placenta to the baby and back out. This starts by day 17. All right, so very, very early on. The things that I want to point out for fetal circulation. The umbilical cord is going to be bringing in all the blood from the placenta. And the placenta, we're going to look at here in a second. The placenta is really breathing for our baby. Okay, this is our respiration. It brings in the oxygen. It takes out the carbon dioxide. It also has the nutrition and is taking out the waste. And all of this happens via the umbilical cord. And so the umbilical cord has 3 vessels in it. And so 2 of them are little and 1 of them is bigger. All right. And these little ones are arteries. And this big one is a vein. I don't know if my marker might not be dark enough. So the arteries take away the waste. The vein is what is bringing in the oxygen. All right, so the oxygenated blood is coming in from mom, from the placenta through the umbilical vein, and then the arteries take the waste back out. All of these vessels are protected by this really fabulous connective tissue that only exists here in the umbilical cord. And it surrounds all these vessels, and it's called Wharton's jelly. Wharton's jelly is it makes the umbilical cord have kind of almost like the consistency of a gummy worm. And this helps the cord to be able to move and flex without compressing, twisting, crimping, tying those vessels off. Okay, because that's the baby's lifeline. The other thing that happens is when the baby's inside, the baby is not breathing and using their lungs. Okay, so we already said amniotic fluid is going in and expanding those alveoli and helping those lungs develop. There's no gas exchange happening here. Okay, so what happens with the baby's heart is different than your heart and my heart. Okay, so if we look, the blood that's coming in from the placenta comes in and hits this first shunt. And this first shunt is the ductus venosus. The ductus venosus takes the oxygen-rich blood that's coming in from the placenta through the umbilical cord, and it sends it up to the heart. Okay, when the blood gets to the baby's heart, we have a couple more shunts that bypass the lungs. So, in my fabulous artistic ability, if this is the heart, and this is the right atrium, this is the right ventricle, this is the left atrium, this is the left ventricle. Usually, the blood comes in here, then goes down to the ventricle, and then goes out to the lungs. There's two shunts that happen for the baby. One of them lives here between the two atria, okay? And this one is the foramen ovale. And so it will let this oxygenated blood that comes in go right over here and then down to the left ventricle and out to the body, okay? Any blood that still goes down from the right atria to the ventricle that would be sent to the lungs hits the other shunt. And the other shunt is up in the picture. It's right here, right? So instead of going to the lungs, it will shunt here. And that shunt is the ductus arteriosus, and that puts the blood into the aorta. Now, you don't have to have all of this memorized, but I want you to know how this works, because later when we have the baby and we talk about what we expect the baby to do in the first 10 minutes of life, these shunts are going to start closing. All right, because now when the baby comes out, takes a breath, we clamp the cord, all the pressure changes in the body, and the shunts start to close so that the blood now will go to the lungs for gas exchange. Okay, so I hope that makes sense. Okay. So the nurse is assessing the umbilical cord of a newborn. Which finding constitutes a normal finding? All right, so we're going to have three vessels. Remember AVA, AVA, artery, vein, artery. Two arteries, one vein. And remember that the vein is where the oxygenated blood's coming from. So our placenta is our other main structure of pregnancy. All right, and we glanced at this a second ago. The placenta has several huge jobs. Okay, it is our metabolic exchange. It is respiration for our baby. It is what's bringing in nutrition. It takes out all the waste and sends it back to mom for excretion. And so the thing that's really important, guys, is that if the mom's blood pressure is varying from normal for her, it's going to affect the way she perfuses her placenta. And many times I'll say, how are we perfusing our placenta? Because if we're not perfusing our placenta, we are not oxygenating our baby well. Okay. And so if the blood pressure is high, like with preeclampsia, and it suddenly goes really high, then we have a lot of resistance for that blood getting into the placenta. Oftentimes what happens is the blood pressure will be low. If we give mom in labor, we give her an epidural. Epidurals are notorious for causing the blood pressure to drop. And if we drop the blood pressure, how are we perfusing our placenta? Not as much. So now we're not getting as much oxygen to our baby, and we're going to see that. We're going to see signs of that with the baby. We learn about that next week. Okay. So the placenta depends on the blood pressure to function properly. Okay. Placentas are not meant to be lifetime organs. All right. So they grow and they do their job. And then as they start to get at and past the gestation, the due date for the baby, they start to calcify and we have less blood flow through the placenta. Okay. The other thing that's really important is that if we look, and this picture is really busy, but what I want you guys to be able to really differentiate here is that we've got, you can see where it shows the fetal blood, and you can see where it's showing like the spinal arteries, and you can see where these exchanges are happening. There is not ever a mix between mom's blood and baby's blood. All right. Everything diffuses back and forth. All right. So we're not having mixing of blood. The baby's vessels are in here, and then in the intravillous space, mom's blood is there, and the vessels are there so that we can, from the baby, so that we can have the diffusion back and forth, but the blood's not mixing. Okay. And so the other thing that the placenta is doing, besides, growing a baby, is it's producing hormones. So the big hormone that it's producing is progesterone, and progesterone helps maintain the pregnancy. Okay. And so it also produces some estrogen and a couple other things. Estrogen, so when I think about these two hormones, I think progesterone protects. It protects the pregnancy. Estrogen enlarges. So estrogen is going to help the uterus grow. It's going to help the breasts grow to accommodate the forming milk and colostrum and things like that. So that's the other thing the placenta is doing, is producing hormones. Okay. A pregnant client asks about the functions of the placenta. Which items of information should the nurse include in the discussion with the client? So for this one, the placenta is not filtering out alcohol from the mom's blood. Fetal and maternal blood mix within the placenta to exchange oxygen nutrients. They don't mix. Okay. Fetal respiration, nutrition, and excretion are carried out. That does happen. Oxygenated blood from the mother is diffused into the fetal blood as it's channeled through the umbilical cord. So this does happen, but not in the umbilical cord. This is also happening in the placenta. So that's still not the correct answer. So number 3. All right, so next topic we're going to work on is gravidity and parity. Okay, gravidity is the number of times that the woman's been pregnant. Okay, it does not matter how many babies were in there at the time, if she had twins, triplets, whatever. It does not matter how the pregnancy ended, if she had a miscarriage, if she had a delivery, if she had a C-section, if she had an abortion, it doesn't matter. It just matters that the pregnancy happened. Okay. And so then we have some terms that go with this, right? So we've got prima gravida. Prima means one. So if a patient is a prima gravida, she's pregnant for the first time. Okay. Multigravida is more than one, multi. So she's had more than one pregnancy, so 2 or more. Nulla gravida is 0, null. So she's never been pregnant before. Okay. Parity is the number of deliveries. And this is the number of deliveries when the fetus has reached 20 weeks gestation. So why is 20 weeks our magic number, do you think? So we use 20 weeks because that is what we are going to consider the age of viability. So prior to 20 weeks gestation, it's considered an abortion. So if her body delivers spontaneously before 20 weeks gestation, that's a spontaneous abortion. If it's after 20 weeks gestation, it counts as a delivery under parity. Okay, so this also does not matter how many babies come out. Okay, if she's pregnant with twins and she delivers twins, it's one delivery. All right. So parity is the combination of our term and preterm. And I'm going to show you what that means in a little better on the next slide. So we are going to use terminology for this too. So prima, again, is 1. So if we have a prima para, she has delivered one baby greater than 20 weeks gestation. If she's a multipara, she has delivered more than one baby, more than one pregnancy, greater than 20 weeks gestation. Okay, so I want to clarify, I don't want to say more than one baby because then that would imply that twins counts as multi and it's still only one. Okay, so this is if she delivers, completes a pregnancy, more than one pregnancy past 20 weeks, she's a multipara. A nullipara has not ever completed a pregnancy. So you can have a patient who's a multigravida nullipara, because maybe she's been pregnant multiple times, but she's not completed a pregnancy with a viable fetus. Maybe she unfortunately keeps having spontaneous abortions. Okay. You can also have a patient who's a multigravida and a prima para. If she's pregnant with her second baby, she's a multigravida. But until she delivers the second baby, she's only delivered the one, she's a prima para. So sometimes these terms can shift, just depends on circumstance. All right. So now to dig a little deeper, we're going to expand on this a little bit, and we're going to do the obstetric history. And the obstetric history is GTPAL. And so our G is our gravidity. It's the total number of pregnancies. Okay. Now our T is term deliveries. And so these are deliveries that happened at term. So if you think about what you might already know, what would you think term is? So term is going to be greater than 37 weeks and 0 days gestation. Preterm is before 37 and 0, but it's still after 20 weeks, remember, because that 20 weeks is going to be the cutoff. Before 20 weeks is spontaneous, or maybe it wasn't spontaneous, maybe she had an abortion. But spontaneous abortion, miscarriage, whatever terminology you want to put there, it's not going to count in our parity. Okay, so we'll write it out and we'll say G T P A L. And T and P is the parity, right? Because this is our term deliveries greater than 37 weeks, and this is our preterm deliveries between 20 weeks and under 37. So 36 weeks and 6 days. These combine to be our parity. All right, but we're going to spread them out like this. L is our living children. So if you have twins, this is where we pick up the twin. All right, so if she's pregnant for the first time, she's a G1, and then she delivers twins at 35 weeks. That's not term, so that's a 0, but it is preterm, so that's 1 delivery at 35 weeks, no abortions, living children 2, because she had twins. All right, so let's practice this way. So a pregnant client is making her first antepartum visit. She has a 2-year-old son born at 40 weeks, a 5-year-old daughter born at 38 weeks, a 7-year-old twin daughters born at 35 weeks. She had a spontaneous abortion 3 years ago at 10 weeks. Using GTPAL, the nurse should identify the client is wet. So since this is a video, you can pause if you want to practice, and I'm going to solve this. So she is currently pregnant. We're going to do tallies to count these pregnancies. She's currently pregnant because she's making an antepartum visit. She has a 2-year-old. She has a 5-year-old. She had 7-year-old twins. That counts as 1 pregnancy. And she had a spontaneous abortion. Okay, so I'm counting 5 for her pregnancies. So she's a G5. Okay, now let's figure out how many are term. So remember that term is greater than 37 weeks. So her 2-year-old was born at 40 weeks. So that's a term delivery. Her 5-year-old was born at 38 weeks. So that's a term delivery. The twins are born at 35 weeks. That's not term. And then she had the spontaneous abortion. So for term, we get 2. The 2-year-old and the 5-year-old. All right, so now we're going to look at preterm. Preterm is less than 37 weeks, but greater than 20. So we already counted the 40-week boy as term, and we counted the 38-week daughter as term. The twins are preterm. Okay, the 7-year-old twin daughters are born at 35 weeks, so that's less than 37, so they're preterm. So for under the P, are we going to put 1 or 2 for the twins? Counts as 1 delivery. Okay, for the twins. And then she had the spontaneous abortion, so that goes over here under abortions. Living children. She has a 2-year-old, the 5-year-old, the twins. She has 4 living children. So her obstetric history is G5, T2, P1, A1, L4, and that is letter C. Okay. All right. So there are other places we can practice that, and we're also going to practice it in class. Signs of pregnancy. So guys, the G's and P's, the GTPAL, the gravidity and parity, and signs of pregnancy that we're going to review next, all this stuff is all stuff that's going to show up on your exams and on HESI. Okay. Signs of pregnancy. So for these ones can be a little bit confusing for some people. To try to help you remember, I've changed the color in a couple of our letters. So first we're going to talk about presumptive signs. So the S in presumptive is green, and then these are subjective information. So we're reminded that the S means subjective. Subjective are things that your patient tells you. Okay, so examples of this here. Signs that are subjective or presumptive signs of pregnancy. Amenorrhea. I missed my period. Fatigue. I've been so tired lately. Nausea and vomiting. Every morning I have to run to the toilet and barf. Quickening. Any idea what quickening is? Quickening is the very first sensations of fetal movement. And so this usually actually happens in pregnancy around 18 to 20 weeks gestation, but they feel like little flutters. And so I don't know if she's feeling fetal movement. She could be feeling gas bubbles. I don't know. So it's still subjective. So I think I feel my baby moving. Quickening is also subjective or presumptive signs. Probable signs of pregnancy. Probable has an O in it, and it reminds us that these are objective signs. So probable signs of pregnancy, these are things that mean she's probably pregnant. Okay. And so probable signs are going to include things like positive pregnancy test. If you are the one that does it, if she comes to the clinic and you do the pregnancy test and the lab comes back and says, yep, she's pregnant, that's a probable sign. Okay. Cervical changes. So for our cervical changes, different things happen in pregnancy, okay? To not just the cervix, but to the vulva and the vagina and stuff like that. So and so that's what these other things are: Chadwick sign, Goodell sign, Hagar sign, and McDonald sign. So these are either softening of the cervix, of the vagina, of the lower uterine segment. These can be the change in color. So Chadwick sign causes a bluish purple look on the cervix and the vagina and the vulva. And ballottement is when if the examiner puts their fingers through the vagina and touches the lower uterine segment cervix, that they can feel something rebound or bounce away. Okay, these are all signs she's probably pregnant. All right, but the only way to call it positive, I am positive she's pregnant, these are positive signs, is if we can attribute it to the fetus. So with this, we're talking about being able to hear the heartbeat on Doppler, being able to see the baby on ultrasound. If the examiner can palpate or visualize movement of the fetus, either on ultrasound or like if they can palpate and see it with their hands, but this has to be from the examiner's point of view. So these are things that are from the baby. All right, it's only positive if it's actually coming from the baby. Because these other things like the positive pregnancy test in the clinic and all these signs, Chadwick sign and all these things, she probably is pregnant, but there's certain things that can happen in the body, like tumors and things like that, that can mimic these things. Okay, so they're not 100% definitive. Okay. The client who thinks she's pregnant comes into the prenatal clinic to begin care. Which data provides the most definitive confirmation of the pregnancy? So number one, the client states she's not had a period for 2.5 months. That's the client states. That's subjective information. That's presumptive. Positive Chadwick sign. So that's that blue discoloration. That is probable. She's probably pregnant. Changes in breast pigmentation. That is also not positive. This is something that is presumptive because you don't know what her breasts looked like before. And so she says, my breasts look different. Okay. Fetal heart tones auscultated by the Doppler. That's a positive sign. So that would be the most definitive confirmation of her pregnancy. I'm positive she's pregnant if I can hear the baby's heartbeat. So things that are happening in mom's body during pregnancy. Cardiovascular changes. So one of the things that happens for the mom when she's pregnant is her blood volume goes up. Okay, because she has to be able to circulate blood through the placenta and all that. So her volume increases by a lot, 30 to 50%. And so now her cardiac output is also increasing because her heart has to work harder to just pump all that blood. Sometimes the heart rate also goes up because of this. All right. For her blood pressure, though, her blood pressure shouldn't increase. Excuse me. So, so the blood pressure, it's there's a lot of other things going on in the body with hormones. There's things and prostaglandins and things that help the vasculature relax and accommodate this extra blood volume. And so the blood pressure should stay the same. If we're seeing increases in blood pressure, then we are thinking about these factors on the slide. Okay, does she have anxiety? Is she in pain? Sometimes they come in labor and they're huffing and puffing and their blood pressure is high because they're in pain. All right. Sometimes positioning of the cuff or and size of the cuff. If it slides down on her elbow, it's not very accurate. If it's not the right size, her position. If I lay her on her side and her arm is up that I'm taking her blood pressure on, I'm going to get a different blood pressure than if she's downward. So remembering what we learned about how to take an accurate blood pressure and the legs aren't crossed and the arm is at the level of the heart and those things can affect. Okay. So there's a lot of factors that affect the blood pressure, but we're not anticipating a blood pressure to be outside of her normal range. Okay, so we've got this increase in blood volume going on. Blood pressure is not changing. If the blood pressure is elevated and we're before 20 weeks gestation and we don't have any of these things that we're thinking about for her, then maybe she has chronic hypertension. Okay, if we're past 20 weeks gestation and the blood pressure is increasing, then we're looking at maybe a gestational hypertension, which we learn about later. All right. So as far as circulatory changes go, so that's the issue with our blood pressure. Our blood volume is increasing. The plasma also increases to help that blood volume. So more of plasma is increasing than red blood cells when the blood volume goes up. And so when that's happening, it creates what we call a physiologic anemia, because now we have more plasma and we have less hemoglobin and hematocrit concentration, right? So for your pregnant patient, we don't really worry about true anemia unless the hemoglobin's less than 11. And so this is our physiologic anemia. Also, pregnant ladies are hypercoagulable. So that means they can develop blood clots easier. So increased risk of DVTs. We don't want her sitting for long periods of time. If she's going to be sitting for long periods of time, we want to encourage her to, move her feet around, flex and relax, keep contracting the calves, things like that. The other thing too that can happen that affects circulation is called supine hypotension. So if we look at the picture over here on the right, you can see the heart and you can see the vessels as they come down from the heart and they run back behind the uterus. So supine, I learned supine on your spine. If we put her on her back, the heavy weight of the uterus and the baby and the fluid and all the things that are in there can compress the vena cava. And if it compresses the vena cava, it affects mom's blood pressure. We're not getting good blood flow through her body. So she can start feeling lightheaded and dizzy and agitated and feeling like garbage. Also, it affects the blood flow to the placenta. Okay, so because it affects the blood pressure. Supine hypotension. So if we make her hypotensive by putting her on her back with vena cava syndrome, we are decreasing the blood flow to the placenta and we can cause hypoxia for our baby. Okay, so what do you think we should do? If we have a patient that's showing signs of supine hypotension, maybe I put her on her back and maybe I'm doing a speculum exam and I put her on her back and she starts feeling, I don't feel good. What should we do? So what we need to do is turn her, get her off her back. Okay. So the nurse recognizes that an expected change in the hematologic system that occurs during the second trimester of pregnancy is what? So for this, we're looking for C, an increase in blood volume. That's an expected change. We don't expect a decrease in white blood cells. We don't expect an increase in hematocrit. Remember, that actually goes down. And we don't expect a decrease in sed rates. So C, an increase in blood volume. More changes. So many things happening in the body with pregnancy. Okay, so this is just a bit of them. All right, they're in the book. There's a whole table in the book. Okay, so here's just a bit of the things that are happening in her body. So respiratory wise, she might feel stuffy. So we have that excess blood volume, right? We have more. And so it can cause her to feel congested and also can cause the engorgement in the capillaries, can cause her nose to bleed. That could be normal. Skin changes, we can see discoloration on the skin. This is usually just caused by hormone changes and progesterone, but they call chloasma or melasmas on the face. Linea nigra. Linea nigra runs on the belly from about the belly button down to the pubic symphysis. It's like a line. We can also actually see then the areola of the breast getting darker. Striae gravidarum. What do you think? Stretch marks. Okay. Renal wise, in the early pregnancy, we have more urinary frequency and urgency, and that is caused by, if we go back here for a second, oh, I went too far. You can see urinary frequency because of Hagar's sign. The lower uterine segment is getting softer, and so it's putting some pressure on the bladder, and so she's going to need to pee more in the early part of pregnancy. In the later part of pregnancy, she can need to pee more because the baby's putting pressure on her bladder. Also, stress incontinence. So stress incontinence is if anything that causes pressure on the inside of body, like laughing, sneezing, coughing, vomiting, stuff like that, can cause leakage of urine. The bladder doesn't always empty as well at the end of pregnancy, and so we can have an increased risk of UTIs. And that's concerning. We're going to talk about that with preterm labor because UTIs irritate the uterus and cause it to contract. Gastrointestinal, lots of stuff going on with the GI. So we've got morning sickness, we've got constipation, we've got heartburn, and lots of education and teaching that goes with those. Musculoskeletal, lordosis. Lordosis is going to be, so when she's pregnant, her body is compensating because of change of gravity on her body. So she's going to kind of become more like have that sway back. All right, or lordosis. And so that can lead to back pain. So especially women who are on their feet a lot at work at the end of pregnancy and stuff like that, oftentimes their back is really sore. Diastasis recti abdominis. This is the separation of the muscles in the abdomen. Relaxed pelvic joints. So the body, one of the hormones that the body produces is called relaxin. Relaxin helps things relax. It helps the vasculature relax to accommodate that extra blood volume that we talked about. It also makes the pelvic joints relax to make room for this growing baby, but it makes her a little unsteady. And so that's oftentimes why you see them kind of waddle. Carpal tunnel syndrome because of edema, lightheadedness, faintness. Leukorrhea is white discharge. The operculum That's the name for the mucus plug, and it shows up sometimes in school, but I don't really hear it discussed in the hospital, like, "Oh, she brought me her operculum." Um, but the mucus plug lives in the cervix and protects from bacteria entering into, and close to the end of pregnancy, oftentimes the mucus plug comes out. And so women will be like, yes, this came out of me, and they want to bring it to you and show it to you. Breast changes, tingling, enlargement. So remember, estrogen enlarges, and so it's going to help enlarge the breasts and prepare for lactation. Um, And then we have our hormones. And so estrogen protects, progesterone protects and estrogen enlarges. So here is a picture that shows a lot of the different things that are changing. A lot of them are on that previous slide, but this kind of gives a picture that goes with it. Okay, all of these are common things in pregnancy, common discomforts. And so psychosocially, when a woman's pregnant, oftentimes there's, for her, she can start out the pregnancy, even if it was planned, as feeling a little conflicted. Like, I don't know if we can afford it. And, I don't know how this is going to affect my other kids. And oh my gosh, we had a trip planned and this is going to change my life. And it's not unusual to have some ambivalence at the beginning of pregnancy. If we're feeling like that at the end of pregnancy, I'm concerned, but at the beginning of pregnancy, I'm not. And then as the pregnancy progresses, then it starts to become more real to her, and she starts taking on that mother role. By the end of pregnancy, she's over it, she's moody, she's tired, and she's ready to be done. For the dads, it's different for a dad because the pregnancy is so abstract, compared to for the mom who can actually feel the baby moving and those things. So they also can have some ambivalence to start. And then they start to adjust and they start wanting to plan and they want to figure out the finances and they want to become active members of this process. And then the focus phase is when they really start feeling like a dad and participating and stuff like that. All right, lots of things to consider for dietary. Okay. So nutrition correlates with fetal health. There's a lot of evidence that says that poor nutrition can contribute to some of our conditions like preeclampsia, which is not good. It affects the way we grow our babies. And so when we think about nutrition, we're going to think less about the number of calories and we're going to think more about the weight gain we're trying to achieve. And the reason for this is because if I say you need to have 350 to 450 calories per day, true. But you could drink a Coke and say, got it. And that's not going to get you what you need. Okay. So even though we know that that's our ballpark, what we're looking for, it's okay to mention that to mom so she doesn't think she's eating for two. But at the same time, we really want her to focus on picking nutritious foods that give her those additional calories. And we're going to teach about the weight gain that we want to achieve. And so the weight gain that we're trying to achieve, typically for a woman who had a normal BMI before she got pregnant, which normal BMI before pregnancy is 18.5 to 24.9. And so if she's in that normal range, then we're going to anticipate that she will gain 25 to 35 pounds. And the first trimester is only like 4 pounds of it. Okay, because there's not a lot of significant growth that's happening at that point. We're not building up a lot of fluid and all those things until later. And so it's only like 4 pounds in the first trimester, and then about a half a pound to a pound a week for the rest of the pregnancy. Now, if she's obese, if her BMI is greater than 30, which is how we define obesity, they might recommend her to gain less. Okay. But for the most part, the numbers to know is that 4 pounds the first trimester, half a pound to a pound a week. Okay. So that we gain 25 to 35 pounds. And we want to teach her to do it with good nutrients. And so examples of good nutrients are on the slide. So we want to, and they're also in your book on page 206. We want to encourage her to eat foods that are high with DHA. We're going to encourage complex carbohydrates. I think those are actually on the next slide. Let me see. Nope. Complex carbohydrates are going to give her a lot of the nutrients that she needs. Folic acid, we talked about, for helping to decrease the prevalence of neurotube defects. And so a lot of these we're thinking about what foods have these items. Okay, so like DHA you get with fish and eggs and poultry. Folic acid with beans and potatoes and greens and strawberries and stuff like that. For our vegetarians, this is something that we keep in mind because vegetarians don't eat meat products, so they lack B12. Because we find a lot of the RB12 like in our meats and like our red meats and eggs and stuff like that. So patients that have specific dietary requests or dietary needs, they probably would benefit from having a nutritionist help them out. This is also true for people that have a higher risk of not gaining appropriate weight, like your adolescents. Okay. Other nutrients that we're going to be thinking about for your pregnant patient is iron. Okay, so remember that physiologic anemia is not unusual. Hemoglobin less than 11, though, is probably an iron deficiency. And if she's got iron deficiency anemia, then she is probably going to be taking supplements. And so when we think about how we teach women to take supplemental iron, we don't want them to take it with things that are going to interfere with the absorption. So if we remember what we know about this, then usually students can easily say, don't take it with milk. Okay, so that's good because the high calcium foods is going to interfere with absorption, but so does coffee, so does tea. All right. And also pregnant women are notorious for eating Tums, which are high in calcium, which would interfere with the absorption. Okay, taking with vitamin C is better. And then remember to teach them that it can cause their stools to be dark. For constipation and bloating, our patients have increased risk of constipation and bloating, so we're teaching fluids, high fiber diet, ambulating. Okay, they can also, depending on if they have orders for like a stool softener, Colace is often taken in pregnancy as well. Heartburn and nausea, vomiting, and pregnancy. Both of these, even though they're different, a lot of the recommendations for these are the same. So with heartburn, we're thinking about small frequent meals. We're thinking about sitting up for a while after you eat. We're not doing spicy or acidic foods. Warm drinks like warm tea can help in between meals, and sometimes milk helps to coat it. Okay. But nausea, vomiting, and pregnancy, again, we're avoiding the empty stomach. We're doing small, frequent meals. For nausea and vomiting and pregnancy, that's usually your morning sickness. If they keep a little like carby snack next to the bed, like crackers or Cheerios or something like that, and they eat a little before they even get up, sometimes that'll help. In an effort to not let the stomach be too full, if they alternate food and fluid, then the fluid isn't expanding the food. So alternating is good too. But again, no spicy, no acidic, stuff like that. Pica. Pica is something that happens, and it's often a sign of an iron deficiency. And so it's very often seen culturally. African Americans and Hispanics are the ethnicities we see it the most in. And these moms want to eat or do eat things that are not food. So we're thinking about clay, chalk, freezer frost, starch, stuff like that. All right. And so if this is happening, if you have a patient that is consuming these items, we need to address this. We need to ask them um, how much that they're eating so that we know, like, because it's a safety issue. But we also need to consult the physician and get lab work to see if she's iron deficient so that we can get her on iron. And then we go back to the considerations for iron that we were discussing in the previous slide. Um, Adolescents. So patients that are adolescent tend to have difficulties with nutrition. And some of this comes from the fact that they're still growing and their body's taking the nutrients it would be giving to baby. Some of it comes from the fact that they're not making good choices with the food they're eating. They have body image issues. They don't want to be fat. There's a lot of stuff. So adolescents are at a higher risk of having babies that have low birth weight. They also have a higher prevalence of anemia. So this is a patient that also would benefit from a dietitian. Also true with diabetes. We'll spend a lot of time talking about diabetes, but the thing that's important nutritionally for your diabetic is to maintain this nice, consistent blood glucose level. Okay, we don't want the ups and downs, the peaks and troughs. So for our patients, when we are, a lot of the things we discussed in class, as far as things we want to know when we first meet a patient, and the first appointment. Okay, and we discussed it in class in week 1 more in relation to any woman coming in for an appointment. But we did a good job in class identifying things that we wanted to know, like obstetric history, sexual partners, stuff like that. So a lot of that applies to this as well. And we did touch on also the importance of screening every time for intimate partner violence. Okay. And the reason for this partly is because that sometimes the abuse hasn't happened yet, and it happens throughout the pregnancy. There's times that pregnancy increases the stress in a relationship. Sometimes they're in the honeymoon phase, and so they're not really talking about it because they're believing it's not going to happen anymore. So if we see signs of intimate partner violence, so even though we're asking those questions, if we're seeing signs, then we also are making sure that we are providing that patient with resources to stay safe. Um, so we can ask her if she wants us to intervene, and most of the time she doesn't. So we can have resources that we can give her, like on a card she can tuck in her purse, so that if at any point she's not feeling safe, she has someplace to go, someplace to call. Lab work. For our lab work, we're going to want to know, we're going to look at her blood count. I want to know if she's anemic to start. I want to know what her platelets are. Platelets are going to matter later. And so I want to know where we're starting. If she has STIs, we would like to know that. If she's HIV positive, it's important to know that at the beginning of pregnancy, because that there's antiretrovirals we can give her to help minimize the potential of the HIV passing on to the baby. Rubella. If her rubella is not immune, then rubella is something that can cause, if she contracted it in pregnancy, can cause problems for the baby. But we can't vaccinate her now because the vaccine is a live virus. And so we will make note that she's non-immune, and we will vaccinate her postpartum. We want to know RH. And so think about if you know why RH matters. We're going to talk about it more in a second, but this is an important one with pregnancy. We can determine the gestational age. We're going to check on the status of the baby. We can listen to the heartbeat depending on how far along she is. We're also wanting to know what those cultural preferences are. Remember that when we talk about relating care, cultural relativism, and relating the care items to her culture, I need to know what those things are, because culture affects a lot of this for women. We're providing education, a lot of different things here. So estimating the due date. So guys, first and foremost, the most accurate way to determine a due date is by ultrasound. Okay, but we do use Nagel's rule to estimate the due date. And so if you remember, the normal menstrual cycle is a 28-day cycle. So Nagel's rule is based on the 28-day cycle. And so what happens here is it takes the first day of the last menstrual period, and then we're going to subtract 3 months and add 7 days. So minus 3 months plus 7 days. Okay. And then if it is going to take us into the next year, we need to add the year. So on admission to the prenatal clinic, a 23-year-old woman tells the nurse her last menstrual period began on February 15th, and her previous periods were regular. Her pregnancy test is positive. The client expected date of delivery would be what? So we're going to use Nagel's rule for this. So if it's February 15th was the first day of her last period. Okay, we want to subtract 3 months. Okay, and so February, if we go February, January, December, November. Okay, we can go 1, 2, 3. November is subtracting 3 months. And then we're going to take 15 plus 7. Okay, so 15 plus 7, and we get 22. And so using Nagel's rule, November 22nd. And this one didn't do the year. So for her, though, we would add a year. So if this was February 22nd, 2023, then actually this one doesn't add a year because, my apologies, because this November happens before the end of the year. So for this one, 2023 would still be the due date. If it's going to take us into the next year, then we would add the year. So for our prenatal visits, in addition to the things we already discussed, there's other things we're looking at. So we're still doing intimate partner violence, and page 51, 52 of your book, I think, has a list of things that we're watching for there. We are going to do our fetal assessment. So kick counts, heart tones. Once she starts feeling fetal movement, we're going to be asking about kick counts. Kick counts is a way to determine fetal movement. And so when she is feeling the baby kicking, we have her count how many times she feels it in an hour. We would like her to feel 10 kicks, preferably in an hour, but it can be up to 2 hours because babies take a nap. All right, so we'll say, and so we have her usually assess this at the same time each day because babies kind of function on a schedule. And so she can pick a time of day that her baby tends to be more active, and then she can count for her kick counts. Fetal heart tones we can listen to with a Doppler. Okay, and we usually can hear that as early as 12 weeks gestation. And then we're going to be doing a physical exam each appointment. And so we're checking her weight. We're checking for urine, or her urine for protein. We're checking her vital signs, especially the blood pressure. We're looking to make sure she's not developing hypertension. gestational hypertension, or if she already had chronic hypertension if we're below 20 weeks. Okay, so remember the weight gain. We are expecting her to gain about 4 pounds in the first trimester and then a half a pound to a pound a week after that. We're measuring fundal height. And so the fundal height, we usually start measuring this after 20 weeks gestation. And we put the tape measure in centimeters at the symphysis pubis, and we measure to the fundus, the top of the uterus. And the number of centimeters that we measure should be pretty close to the gestational age, plus or minus 2. All right, we're not usually measuring this before then. This is when we usually find the baby around the umbilicus. Before then, we can try to palpate it, but it's difficult to feel the fundus until I want to say like 14-ish weeks, when you can start to feel it above the pubic symphysis. And then we get to the belly button around 20 to 22 weeks. So that's when we're going to start measuring. So plus or minus 2 centimeters. So if she's 34 weeks, I expect her to measure about 34 centimeters. If she measures something very significantly different, then that could be an indication that we have like polyhydramnios, too much fluid. If the number's high, it could be an indication that we have a growth restriction if the number's low. So it can clue us into if something's going on. Maybe we need an ultrasound so that we can watch how the baby's growing. But guys, I just put her on her back to do this measurement. So think about what might happen here. Okay. And we're going to talk about it, I think, on the next slide. So education wise, we're teaching so much stuff at these visits. So all that nutrition stuff we were talking about is ongoing education. We're teaching, as we're getting closer to the end of pregnancy, we start teaching about breastfeeding, Kegel exercises, what type of exercises are okay in pregnancy. So we're thinking like low impact, exercising for moms in pregnancy. We're teaching her about things to report, things that would be signs that are concerning. So if she's doing her kick counts and the baby's not moving as much as usual or at all, if she's got bleeding, then that's concerning. If she's leaking fluid, if she has a heartburn with a headache can be a sign of preeclampsia. So these are all things we would be telling her, educating her to report back. Okay. If she's having urinary frequency more than normal, because pregnant ladies pee a lot, but if it's increasing, that can be a sign of UTI. So different things like that. 34-week gestation, multigravida comes to the clinic for her bi-monthly appointment. Which assessment findings should the nurse report to the healthcare provider? So weight gain of 2 pounds, fundal height of 30 centimeters, fetal heart rate of 110 or 1 plus edema in her lower extremities. So she's 34 weeks gestation, and she's here for a bi-monthly appointment. So she comes every 2 weeks. All right. Which assessment should the nurse report to the healthcare provider? Weight gain of 2 pounds. She should be gaining a half a pound to a pound a week. So that should be fine. Fundal height of 30 centimeters. What do you think? So she's 34 weeks. And so remember that the fundal height should be plus or minus 2. So that would get her to, if we minus 2 from this, that's 32, but this is 30. So that's small. Fetal heart rate of 110. Normal is 110 to 160. So that's okay. 1 plus edema in our lower extremities is okay. So B is what we're worried about, that fundal height. A pregnant woman at 32 weeks gestation complains of feeling dizzy and lightheaded when her fundal height is being measured. Her skin is pale and moist. The nurse's initial response would be to do what? So what's going on with her? We're measuring her fundal height. Remember, we put her on her back to measure her fundal height. All right, so do we want to assess her blood pressure and pulse? Do we want to have her breathe into a paper bag? Do we want to raise her legs, or do we want to turn her on her left side? This is a classic description of supine hypotension. And so if I take the time to check her vitals to see if she is hypotensive, in the meantime, I'm decreasing oxygenation to my baby. So really the first thing we should do is turn her on her left side. So D is the answer here. All right, so genetic ID and antepartum testings, things that we can do to test in pregnancy. Carrier screening we talked about earlier. What do you carry? Right, that blood test that we can check and see before she even gets pregnant. Multiple marker screens. So this one, there's a few things that we look at with our multiple marker screens, and it can help detect trisomies, neural tube defects, things like that. Ultrasound helps us with this, but the biggest one that helps us with our multiple marker screen is testing the alpha fetoprotein. And the alpha fetoprotein is a biomarker that we can find in the maternal blood. And if the value is low, that is an indicator for Down syndrome. And so we can remember low down. If it's high, that can be an indication of neural tube defects. And so if we get this abnormal value, then we can move on to other steps that might be, we could do an ultrasound, or we can do an amniocentesis, which I'm about to show you. Chorionic villus sampling. This is an invasive procedure. So my friend I told you that found out that she carried the gene for cystic fibrosis, and her husband did too. It was important to her to know if her baby was going to be born with cystic fibrosis. And so this was something that she did choose to do. And they go in and they take a sample from the placenta, and they can look for chromosomal abnormalities. And this, though, has a risk of causing a miscarriage. Percutaneous and umbilical blood sampling is a very cool thing they can do, where they can actually access the umbilical cord. They can do transfusions for the baby and test fetal blood and stuff like that. That's almost is not something that we do all the time, but babies that are at risk for erythroblastosis fetalis, which has to do with that Rh incompatibility and things like that, these are times that it might be used. The nurse is given the client information on maternal serum alpha fetoprotein screening, which statement by the mother indicates that she understands the screening results. If the test is negative, it means the baby doesn't have any birth defects. If the alpha fetoprotein is high, it could indicate a problem with the spinal cord. If the alpha fetoprotein is low, it means I do not need any further testing. Or if the fetal protein is high, I could indicate Down syndrome. All right, so if it's not going to be 1. If it's negative, that means my baby doesn't have any birth defects. Okay, this just is only an indication of certain things. If it's high, it could be a problem with the spinal cord. That's true. Remember, low for Down syndrome, high for neural tube defects. If it's low, I don't need to do anything. That's not true. And if it's high, it could indicate Down syndrome. That's opposite. Okay, so the answer for this is number 2. So if we want to test further, we can test the amniotic fluid. And so this is called an amniocentesis. This is invasive. Okay, they're going to use an ultrasound. And so you can kind of see in the picture here, they're going to use an ultrasound, and so they can see where the baby is, where the placenta is, and then they're going to insert a needle and aspirate amniotic fluid from inside. There's a few reasons to do this. Early in pregnancy, they can do this to determine congenital anomalies. So if we have an abnormal alpha fetoprotein, this would be definitive to look for Down syndrome and neural tube defects. Okay. It can also determine other congenital anomalies as well. Late in pregnancy, if they look at the amniotic fluid, remember from earlier today, we talked about how amniotic fluid goes into the baby's lungs to help expand those alveoli. And so looking at the amniotic fluid can give us an indication of pulmonary maturity. Are the lungs mature? We anticipate that the baby's lungs are typically considered mature at 35 weeks. And that just means that they have enough surfactant in the alveoli so that they don't collapse down on themselves and they can expand and gas exchange can happen. So if we do the amniocentesis late in pregnancy for lung maturity, we look for something called an LS ratio of 2:1. All right. But either time we do this, whether we do it early in pregnancy to look at congenital anomalies or we do it late in pregnancy for pulmonary, we create a risk. Okay, early in pregnancy, it can increase the risk of a miscarriage and infection, and later in pregnancy, it's still a risk of infection, but it can cause preterm labor. So, for this to be done, you need to kind of weigh the benefit versus the risk. How much do I need to know? And so for like if you are a mom that finds out that your alpha fetoprotein is low and that your baby might have Down syndrome, do you need to know that before the baby's born? Like, does that matter to you? And so for some people it does. It might affect some might even terminate the pregnancy at that point. Or they need to plan. They want to figure out how to best take care of this baby when it's born, and they want to plan for it. So there's a lot of different times that parents might choose to do these more invasive testings. Following an amniocentesis, a client verbalizes several complaints. What complaint indicates to the nurse that the client is experiencing a complication from the amniocentesis? Increased fetal movement, low back pain and pelvic cramping, headache and blurry vision, or epigastric pain. So for this, we just said that an amniocentesis can increase the risk of preterm labor. So low back pain and pelvic cramping would be signs of that. So those would be the things that I would be concerned about. So ABO incompatibility and RH incompatibility. Okay, RH incompatibility is the one that we spend the most time talking about. And so this, and when we talked about what labs do we want to know, and we wanted to know the RH. This is because that if the mom's RH is negative, then we give her something called RhoGAM in her pregnancy. And the reason for this is that we don't know if the baby's RH is positive. If the baby's RH is positive, the mom's body can determine that the blood from the baby is foreign and make antibodies towards it. And that's not going to affect this pregnancy. But if she gets pregnant again and the next baby is Rh positive again, those antibodies can then attack that next baby. And that's that erythroblastosis fetalis that I mentioned. And so it breaks down the baby's red blood cells at an alarming rate. All right, so I'm sorry. So for this, we want to know if mom's RH is negative, and we're going to give her RhoGAM. So the way that I kind of try to think about this is if mom's RH is negative, she is a plain glazed donut. There's no sprinkles on her. It's negative. If baby's is positive, she's got sprinkles. And they're in the same box together. The mom's body doesn't want the sprinkles. This donut doesn't want sprinkles on it. So it's going to build up these barriers to try to keep the sprinkles away. Rogam is going to take this away. Okay, because otherwise on the next baby, these antibodies will attack this baby. Okay. So that's that's Rh incompatibility. All right. Now, also true, if a mom is pregnant, she's Rh negative and she miscarries, I don't know if the baby she was carrying was Rh positive. So she would also get Rogam. Also true, if something happens that could cause the mom's blood to see the baby's blood. So I'm thinking trauma. She would get Rogam. Okay. This isn't those are not common things, but those are other times we would give it. Otherwise, every Rh negative woman gets Rogam around 28 weeks gestation. And then after the baby's born, they test the blood type of the baby. And if the blood type of the baby is Rh negative, then there's nothing else to do. But if the blood type of the baby is Rh positive, then mom will get Rogam again before she goes home. Okay. For ABO incompatibility, this one's a little bit different, but it can also cause a fetal hemolysis. And so what happens here is mom's blood type is O, which means that her blood doesn't have any A or B antigens. Okay. It doesn't matter if her Rh is positive or negative, but we'll make her positive. If the baby is anything other than O, A, B, AB, if mom's body has been sensitized before, and we don't know without testing, then her body could use the antibodies it currently has against the baby's blood if it's anything other than O. So that causes a breakdown in the red blood cells of the current pregnancy. And so this is not as severe as the Rh incompatibility. But if the red blood cells break down, they release bilirubin, and this increases the baby's risk for jaundice. So the way we can test for antibodies is with a Coombs test. If we do the Coombs test on the mom, we can tell if she has antibodies. So it's an indirect Coombs. If we do the test on the baby after the baby's born, we can see if the antibodies are on the red blood cells of the baby. And that's a direct Coombs test. These babies have a higher prevalence of jaundice because of the breakdown of the red blood cells. And so if their test is, we test baby and baby does have antibodies, if the Coombs test is positive, then they watch those babies a lot closer. Right? When they watch their bilirubin levels and watch for jaundice for them. So that's ABO. Other things we're considering. So we do ultrasounds pretty frequently in pregnancy. Okay, it's the most accurate way to estimate the due date. It also can be used to determine if we have a growth restriction. We can look at the fluid level amounts. We can look if we have more than one baby. We can look at multiple gestations. Pretty much any woman getting prenatal care will have what they call a review of systems around 20 weeks, where they look at all the organ systems and make sure everything looks okay. And so they can identify if there's anything concerning. They typically do urinalysis on women somewhere around 12 to 16 weeks to look for what we call an asymptomatic bacteria. So since women have a higher prevalence of UTI, sometimes they don't have symptoms. And if that's the case, then we still have an increased risk that could cause preterm labor. So for some clinics, we'll test, just kind of spot check. The glucose tolerance test. The glucose tolerance test is done on any woman who is not diabetic. All right. If she's diabetic, I already know she's diabetic. Okay. But it's possible to develop, I was going to say it's common, but it's not necessarily common, but it's possible to develop a gestational diabetes that happens just with pregnancy. So we test for that. So at 24 to 28 weeks, we do a glucose tolerance test. If you've had a baby before, that would be when you had to drink the really sweet drink and then they drew your blood. Okay. RhoGAM at 28 weeks for the Rh negative mom. Daily kit counts starting in the second trimester. Group B strep. Group B strep, we test for this at 35 to 37 weeks. So any woman can at any point be positive for group B strep. This is something that kind of can live in your normal flora. And it can come and go. So you might be positive during one pregnancy and not in another. But the problem with group B strep is the way it affects the baby. So if a baby is born in a vaginal delivery and the mom was group B strep positive and not treated with antibiotics, then the baby has a high risk of contracting group B strep, and it has a mortality rate for babies up to 50%. So the group B strep test is just a swab where they look and they see if their group B strep is positive, and if so, those moms get antibiotics in labor. And then Leopold's. Leopold's is a way that we can determine the position of the baby. And so it's just putting hands on the belly and feeling, I think I have a picture. Here we go. So we can feel the fundus and then feel down the sides and then feel in the front to determine which side the back's on. Is the baby head up, head down, things like that. That's Leopold's maneuver. So the nurse is providing anticipatory guidance for an African-American client who's 24 weeks gestation. What prenatal laboratory assessment prescribed at 28 weeks should the nurse include in client teaching? So 28 weeks, multiple marker screen. We do that at like way sooner. Direct Coombs test. That direct Coombs test is what we can do on the baby to look for antibodies after they're born. So that's not at 28 weeks. 1 hour glucose test and repeat HIV. We're not repeating the HIV unless she has risk factors. So the glucose tolerance test is the correct answer. And then on the glucose tolerance test, we do a 1 hour. And if her value is high, they'll do a 3 hour. And so they'll then test again every hour for 3 hours and look at the glucose level. Ultrasound, we kind of discussed already. If she's early in pregnancy, it's a good idea to have the bladder full to help raise the uterus to a point they can see. Okay. If we're like at the very end of pregnancy, we usually have them empty their bladder for comfort. But most of the time, full bladder, like when they're doing review of systems, full bladder is going to help them visualize. Other things that we can assess for high-risk pregnancies. So if lots of things that can contribute to a high-risk pregnancy, some of them are things that are completely preventable, like we talked about earlier with smoking and alcohol use. Those two really affect the way we grow our babies. Smoking causes growth restriction, and the reason for this is that smoking causes vasoconstriction. And so when you think about how we are growing our baby, if we have chronic vasoconstriction, that affects how we're perfusing the placenta over time. And so those babies tend to be smaller. Alcohol can cause cognitive impairments for babies and what we call fetal alcohol syndrome. We can also see, we've already talked today about how genetics and nutrition and all these different things can play a role. And then socio-demographic factors. So this was something we touched on in week 1 about access to care and ethnicity, because they had, like, for example, all of the things we looked at for African Americans and the risk factors in pregnancy, they also have the highest rate of preterm birth. And so that can play a role and so certain things can make women fall into a high risk category like that. Um, and so here's an idea of all of those different things. Things we can do to test and to check on our babies. Okay, so the biophysical profile. The biophysical profile is something that it's testing that is very reliable for fetal status in that it looks at more than just a non-stress test that's included, but it uses ultrasound and it looks for breathing movements. So we talked about how the baby's body makes breathing movements and it breathes in and out the amniotic fluid. It looks for fetal movement. Is the baby moving around? It looks at fetal tone. It looks at how much amniotic fluid is in there. And a biophysical profile score that's high is very reassuring. A score that's low is very concerning. And so oftentimes if we have a low biophysical profile score, we might be looking at delivery. Okay. Because that can be an indicator that our baby's compromised and we don't want to let it become worse. Daily fetal movement count or kick counts we talked about before. Have her assess at the same time each day. She should feel 10 movements in 1 to 2 hours. Non-stress test. So the non-stress test is the most widely accepted fetal evaluation for well-being and oxygenation. So what that means is if we have a high-risk pregnancy, oftentimes they will bring that mom in for a non-stress test once a week, twice a week. And what they do is they put the monitor on to look at the baby's heartbeat. And they can see how the baby's doing just because we will look in next week at fetal monitoring. We're looking for reactive tracing. So we're looking for a heartbeat that's in the normal range of 110 to 160. We're looking for moderate variability. So that's going to be our squiggly line on our tracing. We're looking at accelerations from the baseline and no decelerations. And so those are the criteria for non-stress test. And when that is all reassuring, then that gives us a good evaluation that the baby's well oxygenated and doing well in that moment. Okay. And the criteria for the non-stress test, we're going to look at more later in week 3. A contraction stress test is the same idea, except that we actually create stress. We give her contractions so we can turn on oxytocin that makes her uterus contract, and we see how the baby tolerates the contractions. And so that's called a contraction stress test. If that's being done, she's in the hospital, we are monitoring, and that might determine what we do next. If the baby's not tolerating contractions, then that might mean that we need to deliver by cesarean. And then we're going to play Kahoot game in class. So that is the extent of our week 2 content. So I appreciate you hanging out today, and I hope you have a great day.